Welcome to the 8th hands-on workshop for ERCP. It's a pleasure to see the honorable faculty present from national and international borders, and it's wonderful to see you all again. We're also very glad to be joined by these candidates, some of whom we've worked with before and some who are here for the first time. I hope you have a wonderful experience. It's wonderful to see them here from all across the country and internationally. These next 3 days will be quite an experience. Just to highlight, this is the only hands-on training ERCP workshop in the world, and we're very honored for you to be a part of it outside of the UK. We're going to be starting our program, and we'll be starting with Tilawat. So, Mustafa, if you could join us.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم لإيلاف قريش إيلافهم رحلة الشتاء والصيف فليعبدوا رب هذا البيت الذي أطعمهم من جوع وآمنهم من خوف صدق الله العظيم.
I would like to call Dr. Saad Khalid Niaz on stage, if he can have a few words.
Bismillahirrahmanirrahim. This is our 8th hands-on course, and time really flies. Yeah, I mean, he has started with Waqar and then and Khalid, and now we have this. So I'd like to welcome you all. First of all, I would like to thank the faculty, international faculty, starting with Dr. Waqar Ahmed, Khalid Hassan, Mustafa Rai, Dr. Nadeem Tehami, and shortly Dr. Yasin Nabi Tayyab, who's from Lahore. I'm also very grateful to Dr. Laik, who has joined us from Makkah, and Dr. Mansoor. Professor Mansoor is head of gastroenterology in Liaquat National Hospital. He's joining here, and he's been they've both been supporting us throughout. So we're very fortunate to have a lot of friends. Dr. Nawal said it's the only course. No, it's not the only course in hands-on course, but there are some features that are unique. These courses we've actually copied from or practically taken from the UK. Hands-on means hands-on. That's why you've only got, this is an exception. This time we have 6 candidates. Otherwise we take 5 candidates nationally. And it's pretty intensive. Intensive for the trainee as well as the trainer. Because in the next 3 days we'll go through, with 6 candidates, we'll go through at least 24 ERCPs. And during those ERCPs, 4 you will be actually doing yourself. But the rest you will also be watching. So, and it'll give you perspective from across the Atlantic, from UK, from Pakistan, and also Pakistan, different centers. So I think this is pretty unique thing about the course. What I already told you is that the faculty is very friendly here. We are here to teach. They've traveled from far distances, arrived last night, and are here in the morning. I must add here, unlike most courses in the world, we don't give them any honorarium. So there's nothing given to them. If they're lucky, they'll get their fare, hopefully. So we are really in debt to our international faculty for not only taking time out, but also actually, doing it voluntarily. Now, before we start, I just wanted to, because This is the first time I must welcome Ilyas. Where is the name here? Where's the bacha here? We have one candidate, Dr. Bashar. Bashar he's from Jordan. Dr. Bashar, in between, our own language will creep in. If you don't understand or you miss something, please do ask. We'll try and keep it in English so that it's easy for you. But sometimes we have to explain or talk in our language, which I apologize in advance. So quickly, what I wanted to do was tell you a little bit about what SIAG is doing. Ajit, slide here. So this is a cashless facility, so we don't have a cash counter here. Okay, so everything that's done in this facility is done without charges to the patient. And the way we fund ourselves is basically by the government and the philanthropists in the city. So there are three elements of what we wanted to do when we set this up. We've been working here since 2006, but in a very small 3-room setup. And we started these courses then in those small rooms with a single fluoroscopy setup, and it was very tough then also. So our three main aims were: one, service to the patients of quality, and for them not to realize that this is free. So if you look at our logo, it says Meyari Ilaj, which means quality treatment, and Izzat ke Saath means with respect. So we didn't want our patients to feel that this is a free facility, so we are doing a favor to them. I strongly believe that in our facility, and probably most otherwise, even if you're charging, the patients are the ones who are actually providing for us. So we should be thankful to them rather than otherwise. And it is more true for our center and the employees here. So the service aspect, I'll just go straight to where is the so anyway, so in the first year, which was 2024, we did about over 10,000 procedures, of which 2,500 were ERCPs. We did about close to 600 in some EUS. That time we had a single EUS system, and now we have EUS in both fluoroscopies and also EUS lab separately. So the numbers are growing, so this year we've already covered that. We did over 100 spyglasses. I think last year we did about 130 spyglasses. This year we'll probably be touching 180, and that includes biopsies and EHL. Our EHLs have gone up, and that's because we found out how to make the EHL probe cheaper, and practically that's what allowed us to now use EHL in anyone we want, practically. Along with that, we've also introduced RFA. So we're doing RFA both EUS as well as for biliary bile duct as well, and the routine work. We recently started 2 years now. We started poems, so we do about 1 or 2 a month. The other aspect was training, which is why you're here. And we have fellows, advanced endoscopy fellows with us, and we have research fellows. And fellowship is for 2 years. And research is for 1 year. And for obviously those who join us as research fellows, there's a very strong chance that they would actually they would be preferred for the fellowship if they've shown that they are capable of it. So that was the training side. So we do one ERCP, one EUS, and 1 or 2 colonoscopy courses here, along with some workshops. We also do short fellowships. So of late, we had somebody from a place called Bajor, which is north of Pakistan. And I can tell you now that ERCP services in Bajor have started. And so we pick up candidates. We also have an international fellow who is not here, who is a Palestinian, and he's the first international fellow that we have. So what are we doing? The third aspect was research and development. We're very small, so in terms of budget as well as in terms of what we're doing, but we have actually gradually developing our research side. So we have observational studies. We're also working on experimental studies now, clinical trials, drug trials, and we have just recently been approved by the Drug Regulation Authority of Pakistan as a drug trial center for both devices as well as for medicines. And we've also started registries. So the first one we started was a pancreatic registry, and that's through RedCap. We have about 13 retrospective studies that are being done. 2 of them have been accepted for publication. We've submitted, and there are about 10 that are ongoing. 2 accepted and 1 submitted and 10 ongoing. There's some prospective work done, about 6 of them. 1 has already been submitted, 5 are ongoing, and case reports. We'll just quickly share the trials. So observational studies that have been published are basically our ERCP data, which is over close to 13,000 patients. That's been published. Endoscopic ultrasound guided anomaly that I. Oh, yeah, Azad? I'm sorry. I'm sorry. I thought it was coming. So you can see, ये दूसरी वाली पे please आ सकता है Azad? Thank you. So I was just mentioning we did some observational work, experimental studies, which is one devices as well as drugs and registry. We do a lot of pancreatic work, and both adult and pediatric pancreatic work. Of the ERCPs, we do about 10% of them are pediatric. And we're supposed to do one today who's 15 months. So, we. So just touching on the observational studies, published 17 years of our work, retrospective work. The interesting case report on a rare anomaly, duplication of extrahepatic bile duct. APC for trapezoid basket, some of them you have seen, it got stuck and we use APC to break the basket. That's also been published. And EUS, guided pancreatic pseudocyst drainage in pediatric population. Submitted for publication, vascariasis, PEG placement we are working on with or without sedation, and PEG tube placement in post-sleeve hysterectomy. Ongoing projects, this is a long list. The interesting one that I think that we're doing is we're looking at and we'll share that a little bit more in detail, is the risk of infection because we are reusing accessories. So what we are doing is we do the standard cleaning that everybody does, then they are sterilized with plasma. And basically what we are doing is we want to find out how many of our patients actually are how many of our accessories and scopes are actually contaminated post procedure. And so there's a full trial going on, and that's a prospective trial. And other than that, there is I know in the West, you generally don't give antibiotics post procedure. But here in Pakistan, majority of the centers use antibiotic post PEG and post ERCP. And the question was, do we really need it here or not? So we're actually doing that. It's a randomized trial. And so these two are very important. The other thing very interesting was use of diclofenac in pediatric population for ERCP. And we looked at the literature and it's not there. So we've actually specially made suppositories for pediatric population to see if it makes any difference or not. So there's some things that are going on. The clinical trial with hepatitis C, and now we're going to be involved in a trial with hepatitis D. The other part of the research is training models development. So we made a model. This is a colonoscopy model, and we've actually looked at the British model, which costs £5,000. And this entire thing is made in Pakistan. And the difference between this and the British model is this also allows you to do polypectomies. So we can train you on polypectomies with this, and that. Other than that, it's almost similar, and the cost is probably 1/10. So we've made. If you look on the left here, that's the model that you will be using. So in training today, you will have two models, one where you will be able to do sphincterotomy, and the other where you will be able to cannulate, wire exchange, stent, etc. This will be done on models before you actually go on. And I would like to have feedback from you to see if it was, if there's any other thing, and in any way we can improve that. The point of making these models is because it's very easy for candidates that are being trained overseas to actually get hands-on or available. It's available to them. Whereas when we look at our setup, it's almost impossible for most fellows to go to US for visa reasons, or even now UK, plus the cost. So what our aim is to actually develop these, and then we'll also going to share it with other units so that our trainees and fellows can be trained on these as it is elsewhere. So the other thing this is the training, these are the training models. We've also developed an EUS model. Other than that, we're also working on making accessories through our own setup. And so here you have the EUS needles. And FNB needles are expensive here. The Boston would cost approximately 150,000 rupees. Most centers in Pakistan, India, and I'm sure most are reusing these needles. They don't admit a lot of times, but I know that Indians do it 4 times at least. That's what I've been told off the record. And the same applies to Pakistanis, I'm sure. We don't use it. Here, we've stopped reusing almost completely. We worked on the needle for FNB. The easiest one was the model of shark. And the cost of just the needle is 1,000 rupees. And if we were to make this separately, I don't think if we had the plastic mold, it would cost us more than 15,000 rupees. If we had large numbers, the cost would come down. But the needles, if we just change the needle, which actually doesn't put a patient in any risk. If you just change the needle, you've taken the risk of contamination out or infection. It only cost us 1,000. So we've actually looked at it. Samples are pretty good. I'll share it with the experts here and see what they say. We made our own pegs. Even mouth guard, the issue was that, at least what we see here is that suction catheter would fall off many times. The guy is actually interested in what's happening. We all get involved. And the suction catheter, when you're trying to find, it's not there. So we've actually made a little opening. And the suction catheter goes there and it sticks on the left side of the patient just through a little opening. And then it's stabilized. So little things like getting polyp collection, this guide wire, savory guide wire, when we get it from Wilson Cook, it's costing us 18,000 rupees. This is made here, and this is 1,000 rupees. So this is something that we've been working on, and as I said, the aim of the institute was to do the three things that we are trying to work on. And obviously, the reason for telling you this is also for you to know, but this is our third year starting. We've only done 2 years. This institute is only 2 years old. So if we can do it, so can you. It's about thinking and it's about putting your mind to it. After telling you about this quickly, what we do is that we introduce the candidates to the faculty so that we know what your experience is. So I'll ask what we want to know from the hands-on first is where are you from, how many ERCPs you've done or assisted. You have a center to go back to where ERCP facility is available. For those who are doing, what is it that you're having difficulty with? Okay, so these are the 4 things I want you to tell me. And so we can start with Dr. Ilyas.
Sir, I'm from Bhutan. I'm working at the hospital Bhutan as a professor of technology. So I have done almost 3 ERCPs under supervision and almost 10 independently. I feel difficulty in cannulation techniques, and I have no expert in placement of metallic stents in the CBD.
Why do you want to put metallic stent? I don't. It's very expensive.
They are very expensive.
By the time patients come to us, they usually don't have more than 3 to 6 months.
Yes.
So why would you want to put
I have no experience as to gain.
So you just want to learn how.
Yes.
I'm just questioning because I think it's different from where they're coming from, and studies might show that they are better. But for me, I don't, because I have to also look at my patient's pocket. Right?
Yes, they are.
We are very fortunate here. We have the availability, but still we are very careful. We don't want to.
We are doing the same. We are only
because it's just not possible, right? You're in a public sector hospital.
Yes, they are not possible.
So then you would be asking your patient to buy it. I'm sure.
Yes.
That's how it works in public sector.
Yes.
So just be wary of that. But we will try and tell you how to place a metal stent. This is a basic hands-on course, so we try not to go that side. But if there is a case where we want to put a metal stent or can put a metal stent, then we'll surely do that.
Okay. Thank you.
Dr. Bashar.
Thank you. Thank you for this opportunity. Good morning for everybody. I came from Jordan. I have my training in a busy hospital. I have assisted in many cases of ERCP. Our mentor, he is a hepatologist, and he was doing liver transplant. So I also assisted in some cases of this liver transplant. It wasn't in my curriculum. And I had the chance to do some ERCPs by myself, alone. I wanted to improve my skill in cannulation mainly, and holding the scope in a position during the ERCP mainly. And thank you.
So how many independent have you done?
Less than 10 cases, yes.
Okay. Great. Well, you are the first international candidate, and because of you, we've extended this from 5 to 6.
Thank you.
No,
Thank
no,
you.
you're welcome.
Thank you.
Thank you for selecting, and let's hope you have a good experience.
You know, I have a talk with Dr. Marwan, a short talk. We are from the same country. I live in Jordan, but he lives in Gaza.
Yeah.
My family, my uncles lives in Gaza.
Oh my God.
Yeah. Thank you.
So,
thank you.
Our hearts and our.
I hoped to meet him, but he told me he.
No, he had to rush.
Yes, he went on a rush.
Yeah, he had some issues in the family side, but.
Thank you. Thank you.
I hope you have a good time. Dr. Fahad.
Doctor.
Thank you, sir. Sir, I've done less than 10 procedures independently. I've assisted a couple of ERCPs. Sir, my prime impediment is cannulation. I would like to learn the cannulation.
Okay. Great. And you are from?
So I'm from Pakistan Army, sir.
We have to be careful, guys. Okay. But you are in Mali, right?
So I'm a Mali.
Mali doesn't have a fluoroscopy facility.
Sir, it has a fluoro facility available in OT.
Okay. But if you want to, you can actually
sir,
go ahead.
You go and do this.
Good. Now.
Assalamu alaikum, everyone. My name is Dr. Daud Ghilzai. I am from Bolan Medical College, and I am assistant professor in Department of Gastroenterology. I did assisted ERCPs at least 50 and at least 20 successful ERCP in my private setup. And in that, I have placed stents and extract stones and sweep balloons and all that. Thank you.
What is your aim?
My aim is to improve my skills, my positioning and stabilization of scope during my procedures. Is all that.
My name is Dr. Ali Kadir. I'm working as a consultant gastroenterologist in Indus Hospital, Lahore. So in my campus, we have basic facility for endoscopies, for colonoscopies. We are doing diagnostics and therapeutic. And inshallah, hopefully in a month or two, we'll be starting ERCP over there as well. So I've done almost like close to 100 cases under supervision and have observed more than, I think, 400, 500 cases. My aim to actually come here is not, it's not very specific. It's general. I need to learn everything which you guys can teach and to improve my skills overall generally. So that's it. Thank you.
Assalamu alaikum. I am Dr. Vikas Ahmed. I am currently working at Hyderabad Medical Complex, Peshawar, as specialist registrar. So I have done different steps of ERCPs. Like initially, stepwise, I have done intubations more than 50. Then cannulations in papillas, where ERCP was previously done. I have done like 10 to 15 cases completely, but that was under supervision. So my primary focus here is to improve my effacement of papilla, do cannulation in native papillas, and learn sphincterotomy in appropriate way. Thank you.
Very interestingly, 5 of you want to focus on cannulation. Cannulation, as you will be told, to make your cannulation easy, there's only one thing, and that's position, position, and position. Okay? Once you've got your ampulla at the right position, then cannulation will become relatively easy. So we have 4 observers here as well. We don't give any hands-on experience. Let me clearly say this upfront because it's not possible. The aim and objective of the course is to focus on these hands-on, and to be able to give you any hands-on it would take time from them. So I apologize because a lot of times when you're giving us feedback, you want 1 or 2 cases, and as much as we would like to, it's not possible. But other than that, I think in the next 3 days, I learn a lot. In the last 8 courses, I have learned a lot of things. Improved a lot of things. So it's just by watching, just by being here, I think there is a lot of learning. So hopefully you'll learn. Naval, we are now, where is Dr. Naval? We are going to our aims, objectives done. So we already have that. And so we'll just go straight to the, yeah. Dr. Shanil, sorry. Dr. Shanil Kadir is going to introduce something that he has been involved in.
Assalamualaikum. So we're just going to take 5 minutes for a logbook that we've created for the trainees. So I think where I trained from in UK, we have a JAG logbook. So everybody who does any procedures, ERCP, endoscopy, colonoscopy, you have to, previously you had to log it yourself. Now these days it automatically goes on itself. And then, you know, and then at the end of the, I know there is a sort of a rough number that after 200 colonoscopies you get a provisional certificate for being a colonoscopist. 300 you get a full certificate, and similar is the case with ERCP and endoscopy. So in Pakistan we find that there is no logbook, there is no way where people can actually put their stuff in, and there's no way to identify that, say if I say I've done 500 ERCPs, you can't say that I haven't done 500 ERCP, and I have no way to prove that I've done 500 ERCPs. So we decided to create a free logbook which can be used in Pakistan and overseas for anybody, where you can put on all the cases that you are doing, and then at the end of it, it gives you, the number of cases you've done. It just automatically gives all the KPIs as well. So, the sedation, how much sedation you gave, less than 70, more than 70, how much was your cannulation rate, how many polyps did you find. So it's sort of a based on the UK based JAG sort of logbook. So we're just going to inaugurate it today, and we would like the faculty to come and please inaugurate and click on it and inaugurate, and then we can show you what we've done. Huh. Yeah. So I will show you all of it, but if you guys can come and just inaugurate, press the button. Huh? करो, अच्छा एक मिनट आ जाए अच्छा सर अच्छा सर एक मिनट बस सर अब आप इसको क्लिक कर दें हाँ सर मैं एक मिनट डाल देता हूँ और इसको बस आपने ओपन करना है login कर
The concept behind this is that
मुझसे कराओगे तो यही होगा
while there are systems
Huh?
in the developed world to monitor your progress.
Sir, एक
We don't have any system. So it's like
अब सर login
your word against my word. A lot of people come here and say,
बस हो गया
हो गया
thank you so this is sorry so this is the page so you have all these on this side we have this logbook entry so if we click on the logbook we have colon ERCP OGD and endoscopic ultrasound so this is ERCP course we'll put on that so we've just got these only 2 sections for everything so putting gender age and then we have procedure role whether it's a therapeutic diagnostic comfort score we've just given you a thing where how to put a comfort score in and whether you observed the procedure where you did independently were you assisted and obviously the drugs we commonly use midazolam and kins and then put the dose of it and then obviously the other bit is the things of the procedure so whether did you go towards the duodenum whether you cannulated it was biliary pancreatic whether you did a sphincterotomy, it was biliary or pancreatic, whether you did a sphincteroplasty, how much did you do it. So it's sort of it takes you all the main bits of the procedure that you want. If you had a stone, the size of the stone, whether you removed it or not, whether you gave rectal NSAIDs, and then once you've submitted it, it will then at the end it will give you on your dashboard. It will come up as a log. So for example, now I've just got this is a test page, so I've got only one procedure log, and which will just show me that how many procedures I've done, how many forms have I submitted, and over the years it gives you your rough number of procedures. So it's got for all of them, so colonoscopy as well, OGD, endoscopic ultrasound, so all of them have the same thing. It's free of cost for everybody. We're not charging anything. There is no requirement. The only requirement is that you have to be a gastroenterology fellow, and obviously you have to be registered with PMDC. So there is a generic admin email. You just email them, and then we approve it, and then you can start using it wherever you are. So there is a section for it which is for local national candidates, and there is a section for international candidates as well. So it's not only limited to local candidates. So they can also put their logbook and then use it as they would normally do.
Is this filled by a person who is
Yeah.
it, right?
So sir, in the UK, because now the system is a NAD system, so when we do the procedure, it automatically fills up in our logbook. Previously, when we used to train, we had to do it ourselves at the end of the list, so that when we have our appraisal or 6 monthly review, then they can see how many procedures we've done. I don't know how it is in the
Yeah,
US.
the big thing was like, especially for the teams when they're putting in, is somebody signing off on that.
So, Khalid bhai, the thing is that after certain number of procedures, they have put in here, but there is a section which is for the DOPS. So there is forms, the DOPS forms that you do now during the course. So after certain number of procedures, then they would do a DOPS form, which would be online as well, and then they get signed off. After they've done that DOPS form, then they get signed off to say that you're signed off for colonoscopy or signed off. But before doing that DOPS, obviously they have to reach that certain number before it becomes activated.
The reason I was saying like there are different sections, which is really good. If you do a sphincterotomy yourself, or you assisted it, if you do it yourself, because the one which is done under supervision, did half of it. That's different than doing the whole procedure. So,
वो फिर DOPS में
somebody needs to sign up.
Yeah, for that there is a DOPS form. Because we haven't at present we haven't, because this is just done in the past 2-3 weeks, So we have not put in yet, but there will be a DOPS form which they can click. So say for example, you've done the whole list. After the list, you can do that DOPS form, and the trainer can say 4 of the procedures he did independently, 1 procedure he was assisted partially, and then that comes on it as well.
So, sorry. One of the advantages we have, because we're starting with our center, is because we have the entire data for everyone. Okay, so we know what is being done. So it's a little easy that way. So candidate, otherwise, I guess where you're going to is that you fill in anything you want. That's right. Who's looking at? Yes. So there are 2 things about it. One, we expect, which may be a little asking over too much, maybe in Pakistan, we expect one to be honest about it. Don't fill it. There's no need to fill it. However, if you're filling it incorrectly, you don't need to fill out of yourself. I know in colonoscopy because I won't say ERCP because, but colonoscopy because people come here and tell us we've done 100, you've done 150, you've done, what is your arterial intubation? No, never failed. Oh God, why have you come for the course? And then you give them the scope and you realize, you don't even know how to hold the scope properly. So I think it is just a beginning. I mean, the idea was let's start it somewhere. And then with time, we will realize that we need to put in. So we are going to be vigilant in our setup. We're going to try and be as close to real data as possible. And then what we hope is that the other centers in the country will also take it up. And then eventually the PSG can actually become the body which is pruning. And if you can put it, then that's it. That is your own data safe here. This is very important when you're training. So while Khalid's point is valid, anybody can fill anything, I think that is worrying, but that is why we are going to be following. But what we can do is maybe we can say that fellows who are doing it from other centers need to have it verified by their boss supervisor.
Especially like that's what you, which is here, they are doing, what they are filling. But this is what happens is people who get credentialed with the hospital committees and all that, anybody can fill anything. So that would be
I think that would be a good point. That those who are not in our centers, they need to be
signed off
by, after a certain numbers, there need to be whatever. There
is a DOPS form for it. So
ये फॉर्म जो है अवेलेबल होगा जैसे मेरे सेंटर में वहाँ का कैंडिडेट अगर करना चाहेगा तो वो आप उसको यूजर आईडी और पासवर्ड दे देंगे एंड दे विल स्टार्ट फिलिंग इट दूसरे जैसे हमने जो चीज कह रहे थे उससे ये कह रहे हैं इसी फॉर्म के साथ एक जगह पे सबमिट का ऑप्शन दिया हुआ है वहाँ पे वेरीफाइड का ऑप्शन दे दिया जाए हर प्रोसीजर के बाद तो उसी वक्त या उसी दिन सबमिशन कंप्लीट होने से पहले वो अपने जिस सुपरवाइजर के साथ उसने किया है वो उसको साइन करे लेकिन यूजर आईडी अलग होनी चाहिए because that has to be verified यानी ये चीज होनी चाहिए it's just like our own docs system.
जी sir. It's just sir because this has never been done in Pakistan before, so we've started and because what we were thinking about is this is a small step towards getting accreditation for units in Pakistan as well. Once you get this sorted out, then the next step would be to start accrediting units to say that you need to have this minimum standards for your unit to be accredited for endoscopy in Pakistan.
So I think it's a very valid point because everything that we do has to be validated. Now the way it works with us, so if a trainee does a list with me, does 3 or 4 procedures, obviously I as a trainer don't have time to do DOPS for each single procedure. What happens is for every 15 or 20 procedures, he has to do 1 DOPS. So he cannot start filling out form number 21 unless and until he has got 1 DOPS form signed off on any of the procedures picked in those 20, whichever we feel or felt is a good learning episode. So if a candidate has filled out 100 procedures, he has to then supply or provide 5 DOPS forms as the validation that those 100 procedures that he or she has entered are validated. So for every set numbers, you can decide among yourself. So for every set numbers, you do 15 to 20 procedures, and for every 20 procedures, you cannot proceed. Or if I say, look, I've got a logbook, and I've done 150 procedures, he said, fair enough, brilliant work. Can you show me 10 docs attached to those 150 procedures? So my procedure means that after every 10 procedures, they have to get one doc stuff.
You can attach a docs from here, and you can ask them, every 10 procedures.
Just to do a. Otherwise, it will not come.
If you make it mandatory, then they cannot proceed further
Without doing it.
without doing it. That would make everyone do it. Otherwise, that's a very
docs form is sort of communication. So you put in your logbooks, you put the docs form there. So it's
not directly observe procedural skills. This is how we relegate our candidates.
That will be after every 150 procedures.
No, after 10 procedures.
So you need
the idea about a doctor. How would your trainer know how you progress?
For example, I am working in the bank, our overall coordinator is in British. And we are like junior gastroenterologists working in the bank team for that matter, but we have been supervised by the senior team in India. So in this system, we can ask them to do lots for us.
In this day and age, it's not a big deal because you can always have a live case here. You know what stops you from putting a little camera and showing what you do? Even if your boss is not there, it can be possible. There are ways that you can do it.
So Dr. Safia. Dr. Safia.
I mean, no, but ideally it's in the same unit. But
Sir. Dr. Safia. Dr. Safia का question है.
Let me introduce Dr. Safia because she's our head of anesthesia. We are very fortunate. We have a department of anesthesia with us. We have five anesthetists, and she's heading that, and that made our life.
And that is why I am asking this question. There are only two options: Domicum and Kins. Domicum, you rightly, that is midazolam. Kins is nalbuphine.
उसको मैं change करा देता हूँ. And there are any other as well.
Kins is trade name.
तो वो मैं change करा.
Okay. And other thing is there is no option of general anesthesia in your logbook.
Ma'am, there is any other. So midazolam Kins, any other. So you just put whether you've given GA. There is like a free text for it.
Okay. Okay, thank you.
How do you know कि ये verified जो है supervisor कर रहा है या supervisor ने यानी मैं I'm sorry but ऐसा possible है यानी CPSP में क्योंकि हम देखते रहे कि वो पता चला supervisor क्योंकि एक लंबा काम होता है आपको वो देना होता है तो वो उसमें आप किस तरीके से इसको वो कर सकते हैं इंश्योर कि ये supervisor ही कर रहा है खुद मैं यही नहीं सर सीपीएसपी में ऐसा अच्छा सही है ये आप सही कह रहे थे ऑनेस्ट हाँ
we will show you how to do it. Now it's up to the other centers. They want to do it, they can do it. They don't want to do it, we're not interested. And you understand what I'm saying? We're only interested in our setup. We want to create an example for the country. Look, this is how it should be done. This is how we are doing. Now it's for the rest of the centers to see whether this is appropriate for them or not. But we can't sit and monitor the candidate lying, putting in 5, and then the supervisor actually saying कि कर दो मेरा sign है ठीक है it's okay. उसको हम नहीं कर सकते. I mean Pakistan has to change. We can't change for what.
So thank you very much. Thank you to the log development team for doing.
Okay, so we will be starting with our course. Throughout these 3 days, you are going to be listening to some lectures, and they'll be by our esteemed faculty. You'll be getting hands-on model experience, and you're going to be having some hands-on cases as well. The observers are welcome to be in the seminar or go to the modeling as well. So we'll be starting our program, and the first lecture will be Basic Radiology and Safety by Dr. Nadeem Tehami.
Thank you very much, Dr. Saad Niaz and team, for the opportunity. I think, as you all know, the course is going to be interactive. We really want to discuss, share issues as you come along. It's a journey that you're starting. And I think the most important thing in a journey is that you set your expectations. This is the first step for those who are early on in their career, and you actually need to break it down. So any skill that you want to learn, you want to learn the skill by breaking it down. You want to focus on what you want to achieve at the earlier part, and then you want to then build on those. So there are certain principles that you will learn, and then you need to make sure that you adhere to those principles throughout your career and your learning. And I think as Saad has earlier mentioned, it's like positioning is one of the key elements that you have to focus on throughout your career. No matter whatever you're doing cholangioscopy, ketoscopy, EUS, RCP, whatever, it's all got to be done, ensuring that your position is maintained throughout. So make sure you set your expectations. You are very clear in your mind what you are here to achieve. That this is what I'm here to achieve, and this is what I would like to achieve at the end of those 3 days, which is why we've written it down. So I think obviously, you're all focusing on the right thing, which is positioning, and then comes the next step, which would be derivation. So we would try to support you in this journey, but you need to have very clear expectations that this is what I'm here to achieve. Make sure you interact, make sure you ask questions, and then the journey that I think Shaneel and obviously Dr. Saad and the team have started, this would be a very good platform for all of you to reflect on your practice. So you do something, and then you go back to it. How have I learned this particular skills, and how do I need to go to the next step? So that reflective process is extremely important. You may or may not have seen a graph in terms of our learning paradigm, which is where on one sort of x-axis you have got the time period and then your confidence level. So when you start off, there's a learning curve, and then you hit a peak. Once you finish your fellowship, you say, "Oh my God, I'm brilliant at it." When you then start independent practice, you hit a bump, and then your confidence level, not confidence level, to some extent, your confidence level comes down. Okay, so you start at a learning curve, you go to the top, and then you say, "Oh my God, I can fly." But then you realize, no, it comes down a bit. Okay, that's got to do with your confidence, but also your confidence level. And then with the passage of further practice, with further supervision, you achieve a plateau. And along that plateau, throughout your career, there will be days when you will feel again on top of the world. There will be other days when you feel rock bottom. Okay, so it's important that we have those things in mind. I think again, reflecting on what Shaneel and team have done is hopefully this platform will take you realizing your. We were all not conscious of our competence, but when you start a journey, then you become conscious of. This is the first step for you to become aware of your unmet needs. And with the passage of time, you will hit a plateau where you will be conscious of competence you've achieved. And a time may come along your career when you become more experienced, and you may not remain focused and may lose that consciousness of the competence. So in the next 15 minutes, we'll start off by discussing something. So ERCP is one of those modalities where we combine radiology with endoscopic skills. So welcome Professor Yasin Abi Tayyib. So modality where we actually combine radiology with endoscopic skills. We are not trained radiologists, but you will realize at a time in your career that you will be able to interpret cross-sectional imaging, other radiological modalities that will become available better than some radiologists who may not have expertise in the GI radiology. And that is where you will have an edge, but it is going to take some time for you to get to that level. Again, practice will help you to get to that level, but we need to be very mindful of our own unmet need or the areas where we need to improve. So my talk is basically going to focus on 3 areas. Some of the common pitfalls that we observe in the practice. It's really important to focus on the radiation safety, and then we'll talk about optimal image acquisition and interpretation, which again, I think you will see throughout this course how it is being done and how those images are interpreted actually when you're right there. Now, one of the advantages of that reflective practice that we talked is, as an endoscopist, you're actually there, you're actually developing a cognitive overload. So sometimes you actually have to step back and look at the bigger picture. That's where the radiology comes in. Because one of the important things to mention about the ERCP is primarily a therapeutic modality. There are very few situations where it adds to the diagnostic paradigm. But most importantly, the role of ERCP in current day and age is all to do with the therapy that you've intended. And so how do you get to that point? Obviously, you need to have enough evidence data gathering before you start a procedure. And that's where your cross-sectional imaging comes in play. Now, I know obviously in under-resourced part of the world, we may not have access to cross-sectional imaging everywhere where you work. So in some cases, you may have to rely on ultrasound scan and then have to proceed to doing an ERCP. But the advantage of cross-sectional imaging is it provides you a clear roadmap. Roadmap is extremely important. You don't want to start a procedure and then realize, oh no, it wasn't a stone disease, this is a cancer patient. Patient then develops a pancreatitis and a resectable cancer then becomes unresectable. So you're not going to be doing your patient a favor if you've started a procedure with any doubt in your mind about the roadmap or in terms of the anatomy or any anatomical variations that you may come across. Cross-sectional imaging is good, but even CT and MRI scan, mostly anecdotal, but we also know that the ampullary lesions or the small stones less than 5 millimeter cross-section imaging are not going to be definitive in those situations. The strictures, Militsi, we've had a case recently where the CT scan and MRI scan both made a diagnosis, provisional diagnosis of a cholangiocarcinoma, but patient actually had Militsi syndrome. So despite having the best cross-section imaging modalities available and the best experts available, the diagnosis was not made until the cholangioscopy. There were at least 3 other cases that I can think back where the diagnosis was achieved after an endoscopic ultrasound scan. CT and MRI scan did not make that diagnosis. So every time you have a case, try to look at the images yourself. Do look at the report, but do not just accept that report with whatever is there in front of you. You actually have to question. You have to question, is that report matches with what I can see on the imaging? So that is the key messages. And I think in this day and age, we also have an advantage. If you've got anything in doubt and if you are working in a center where you've got an endoscopic ultrasound, you can utilize it. If you don't, then you may wish to refer your patient for endoscopic modalities. Now, I have taken this image from a social media platform, and that's to demonstrate why radiation safety is really important. I come across a lot of images like this on social media. And what I do see very commonly that our radiation practices are not up to the standard which are required internationally. But more importantly, from the safety point of view of the clinicians involved. So what do you think is not right in these images? What bit of the radiation protection equipment these endoscopists and these technicians are missing? Absolutely. And why is it important? Because the radiation sensitivity of certain organs is higher compared to the other organs. So high sensitivity radiation organs, 2 key to remember is thyroid and eye. And in our practice, and at least European Radiation Protection Society now recommends using lead protection goggles, given the increased risk of cataract. So important to be mindful of 2 key organs when we are actually performing these procedures on a daily basis. Now, this is me. This is an email I received recently from our radiation protection, because my exposure was way above what was the recommended limit. Why did that happen? Was it down to because I forgot my dosimeter somewhere? Exactly. Or am I truly working hard? Okay. John Bush ki hai. Exactly. Acha. So I think, so having said this, it is safe. So let me kind of reassure you. Okay. So the current amount of sort of radiation currently being used by the endoscopist is relatively small. And the effective dose that we receive is about 0 to 3 millisievert a year. And then the dose actually recommended by the International Commission on Radiological Protection is about 20 millisievert per year. For situations where the annual dose limit sort of exceeds this 20 millisievert, the recommended dose should not exceed 50 millisievert in any particular year. or sort of 100 millisievert over a 5-year period. So therefore that monitoring is important. Radiation is oncogenic. It is a carcinogen. And then there's the epidemiological data that overall it has 10% increased risk of cancer for health professionals. There are obviously ways to sort of go about it when you're not actually involved in the procedure. Then you want to sort of stay away as further as you can with this inverse square law. So as further you are, your exposure does reduce. So current best practices in the radiation protections are, we want to wear protective gear, focusing on those, at least on those two, thyroid and goggles, if you have access to it. I think one of the good investment I would recommend, which I kind of, when I started off, I made it from my own pocket. I bought my own glasses, but it's actually helps you. Second thing is, you actually have to decide on your exposure time. So if you've got a clear roadmap of a procedure, it's a stone disease patients, not a big stone on your MRI scan or your endoscopic or a CT scan, then you don't actually need to do a lot of exposure. You have a very clear objective. You've got a very clear therapeutic intent that in this patient, I've got 1 or 2 stones, maybe less than 10 millimeter, and I'm going to sort of achieve this. You go in, you do a scout fill, you cannulate, demonstrate that filling defect, proceed your sphincterotomy, and clear the duct. You don't actually have to carry on, so you have to minimize your exposure time, because then you'll be compensating a complex procedure where you'll be scanning for half an hour, 45 minutes, or even longer. So, and maintain a safe distance. And I think it's important for you, because if you are doing it, actually, you have to look after your colleagues around you, your staff around you. People who are not actually involved don't need to be close to your radiation exposure site, because there's a scatter effect. So you actually want to position the bed of the patient close to the source of your radiation so that it reduces that scatter effect. And follow, obviously, this principle, ALARA principle, which is that as low as reasonably achievable. So exposure, radiation exposure should be as low as reasonably achievable. We want to make sure that your equipment is regularly checked with your radiology team. You've got a dosimeter. If there isn't a practice in your department, I think most units should have it. And then it's all about sort of training. So I think in Siag here, you guys do your own exposure, isn't it, using your paddle. So some places you may have to rely on your radiographers, so you want to actually train them, make sure that they're actually understand what your objective here is. And then in some cases, obviously, depending on if it involves radioactive materials, so we've had this OncoSil trial where you may actually have to be careful in terms of disposing the radioactive material. So that's the bit about the radiation safety. Realize the limitations of the imaging modalities that you already have, radiation safety, and then comes the image acquisition and interpretation. I think one of the other important thing, or the key principles, positioning, and then cholangiogram. A good cholangiogram is extremely important. You will also see cases where cross-section imaging may underreport, underscore, or may not give you the clear delineation of hilar structures, where your cholangiogram will actually come in place. There are cases where actually good cholangiogram can actually differentiate between a stricture which can simply go on and have a hep judge as compared to some patient who may need a further invasive surgery. So a good cholangiogram can actually help. A simple procedure can guide your surgeons to do even cholecystectomy, depending on the takeoff of the duct. So you want to do a control film, a scout film, to start off, to demonstrate that this is at the beginning of it, because if you come across a complication, then that will be an evidence which you may have to produce for the patients, for the governance team, and obviously for your own practice as well. Now, depending on your case, you may just want to, so what at times if you do it, if you're doing a fluoroscopy continuous, shouldn't be doing it continuously, but in some cases you do. So you do end up saving the whole loop, because two-dimensional static images sometimes may not actually give you the accurate diagnosis. So you may actually have to save the whole loop, starting from the time you injected the contrast, or starting from the time you achieved the clearance of the duct. Or if you started injecting the contrast, and contrast sometimes actually disappears, depending on the patient body habitus as well. So in some cases, you may end up saving the whole loop as well. which may then help, obviously, if you're discussing your cases either in the tumor board or in your MDTs. So again, hopefully last two slides very briefly. Anybody wants to have a go at it? A standard cholangiogram. Which one? You're talking about this? Yeah, so I think that's a good thought. So obviously you want to keep yourself confined. You don't want to do unnecessary filling of either a pancreatic duct or a gallbladder. But obviously in this case there was a filling in it. Again, that depends on where your cystic duct takeoff is. But something you just need to be aware of. But no, in this case this is not an extravasation. This is actually just a gallbladder. Okay, so the basic anatomy remains the same: the common duct, the common bile duct, common hepatic duct, and then your intrahepatic ducts, right and left, and obviously right dividing into right anterior and posterior. The importance here is that if you concentrate on each cholangiogram that you perform, you will be able to rescue situations where you're dealing with a complex hilar stricture, for example, because there are anatomical variation, which hopefully I'll allude to later on in the later slides. But if you keep focusing on each cholangiogram with your procedures, then actually you're training your mind with each procedures. And the time you come across any anatomical variation, you'll be able to realize it. So that's kind of just box standard cholangiogram that you see. Obviously, there's no filling in the pancreatic duct, thankfully. So this is. Now, let's just focus on the image on the right side first. So as soon as the bifurcation, the right duct divides within a 1 centimeter, 2 centimeter into right anterior, right posterior. So usually the one which goes sort of straight up is right anterior, and the one which goes away from it, away from the spine, is the right posterior. Majority of the cases you'll feel this. Left takes a bit of a time before it starts dividing into the intrahepatic biliary radicals. Right actually goes into right anterior and then posterior. Keeping that in mind is just kinds of helps you if you then come across any anatomical variation, which I'll show you later on. And this is just a cholangiogram which I've wanted to show you to see if you can spot the anomaly here. Yeah. So exactly. So cystic duct takeoff. Where is it taking off? Where is it coming out from? So right side, right duct. Is it before division or after division? We can't actually tag, but obviously it's coming out from that time. And what's actually happened afterwards? Bit of a leak. Okay. So yeah. So obviously, so cystic duct obviously shouldn't take off from the right, should it? Isn't it? But in this case, it was. So if this patient had an ERCP before cholecystectomy, there will be a situation when your surgeon would ask you to clear the duct before they do a cholecystectomy. And if you see that anomaly, you want to report it, so that when your surgeon goes and does a cholecystectomy, he doesn't end up causing this problem.
You haven't understood the problem. So where does the cystic duct normally come from? Right? No, cystic duct comes from the tongue by right? So here's the tongue, hepatic duct finishing, you've got the bifurcation, right? You look at where the cystic duct is coming from. The right side. On the right side. So this is the tongue. Go back and clarify.
So यहाँ पे देखिए, where do you think this? I mean, it's not a great cholangiogram, but obviously you can see this is common cystic duct is taking off from the common bile or common hepatic duct. Okay, so in the extrahepatic portion.
This is an important concept. What is the difference between common hepatic duct and common bile duct? Common bile duct forms one sleeve that joins the common bile duct. Right. So by definition, normally the cystic duct inserts into the common bile duct in most cases, right? So the majority is. So that's the anomaly in the next case. That it's actually coming off the right person, right? Which does happen. So as you embark on this journey, it's important to know what's normal and what's not normal. Otherwise, you will not recognize. It's all about what the brain knows, it will recognize. If the brain doesn't know it, you will not recognize.
So I think following that, what Dr. Naveen just said, was that if you've done this ERCP before, let's say the patient had stone, you did an ERCP and you found this anomaly, and you have to inform the surgeon that the cystic duct is coming out of the right hepatic system, right? So that he knows that he needs to reevaluate. So as a gastroenterologist, as an ERCPist or a gastroenterologist, you need to understand yourself, but also understand the implications, and so that you can actually help your patient. End of the day, it's about patient.
I think this anomaly is usually discovered after the operation.
Yeah.
Most of the time, when there's a cystic duct leak, post or left core cystectomy, this anomaly is picked up, and you can let the surgeon off the hook, because that is something which nobody can predict unless he's had an ERCP before that.
Another thing is, it's fine to have this anomaly. Like, it's not something abnormal. It's just a different pattern, variation. So it's not like somebody has this anomaly that something else is like wrong. It's okay. That's the other point.
Are we okay time-wise? So I think during the course, you'll also see how to actually perform the cholangiogram. Okay. Two elements is one, obviously, where cholangiogram where you're performing to confirm the diagnosis, and second is when we're actually confirming your therapy.
Sorry, given the normal system, duct size, what is the duct size which would class it as a normal? When you're doing an ERCP, you can just add that.
I think that's another important point. What is the normal duct caliber? Because this is, you get a lot of referral in your practice saying, "Oh, I've got this patient who's got a dilated duct," and then you're left in a sort of wondering what to do next. So let me just come to it. So I think one of the important things is, so cholangiograms, two broad concepts. One is your initial cholangiogram to confirm the diagnosis, which you knew already before you started off your journey. And second is your cholangiogram to confirm your therapy. So maybe starting off a cholangiogram, if it was done for a stone disease. Now, Dr. Hassan has got a beautiful way of sort of demonstrating it in the live case, which you will see. But you actually want to divide the occlusion or a completion cholangiogram into two bits. One where you're actually looking at the intrahepatic ducts, and the second is where you're looking at the extrahepatic ducts. Okay? So you divide your completion or occlusion cholangiogram into two bits, extra and intrahepatic ducts. For the intrahepatic ducts, okay, you want to take your catheter, again, you'll see this in the live demonstration, right at where you see the bifurcation of the intrahepatic ducts. Now, by that time, you would have cleared the duct, you would have done a sphincterotomy, and if you start injecting cholangiogram, if you start doing a cholangiogram the normal way which we do it with an occlusion cholangiogram, you will be able to sort of see what's happening in the intrahepatic ducts. But the problem there is, if you do that, by the time you would have done it, sphincterotomy, depending on time you've spent, depending on the amount of gas or the air that you put in, you may have lots of air bubbles. So before we do occlusion cholangiogram, starting from the intrahepatic ducts, you just want to inject a contrast. You want to see that contrast coming out at the sphincterotomy site. And at this stage, we are not doing a radiation exposure. So no radiation exposure is required. You know your catheter tip is there. You're just injecting the contrast, and you will see in some cases actually bubbles coming out. Then when you see the contrast draining, you stop at that stage. You want to take a picture at that stage that you've now filled the intrahepatic ducts. At that stage, you inflate the balloon, and then you do the intrahepatic cholangiogram. Okay, by doing so, there are two advantages. One, you will not confuse yourself by putting some air bubbles into the intrahepatic ducts or by forcing small stones into the intrahepatic ducts, which can then cause intrahepatic sort of collections, abscesses, lots of problem for the patient. So it is incredibly important if you do it precisely. So that is to do with the intrahepatic. I'm sure Dr. Hassan will demonstrate it and explain it in a lot more sort of slick way, but that's one way of doing it, or that's how I've kind of learned from it, or I'm doing it. And then what you do it, you then basically inject at the same time, and then you bring your balloon down. So you do a occlusion cholangiogram by slowly withdrawing your balloon all the way down to your sphincterotomy site. And now you're actually focusing at the extrahepatic portion of the bilby ducts. Clear? So dividing in two bits, intrahepatic and extrahepatic.
So how do you keep your dilation levels, the contrast dilation levels?
I mean, depends on which unit you work. We use 50-50. Okay. Some cases, obviously, you may have to go with the pure contrast, depending on what the indication is, what the patient size is, how long how long have you done it. You'll also see there's a huge air bubble, which also happens longer you stay there. It just fills. Sometimes it sort of degrades the image quality as well. So number of things can happen, but 50-50 tends to work really well in our unit.
Yes. Is that the same for? Sorry. Is that the same for transplant strictures and complicated strictures, or do you go for?
In our practice, we use half-half, except for pancreatic. Pancreatic, we don't want to inject too much because if there's a thing you don't see it, so you can actually see it most of the time. Prefer pure dye for pancreatic. But other than that, by and large, you can do it. The reason why they are half-half was because of the filling defect. Mainly helps you in the stone. But other than that, I mean, you can use the more dye you use, the more sticky it becomes. That's one of the problems. So you need to wash it. I think half or it depends on what you're looking at.
So yeah, so that's kind of occlusion. And the initial one, again, is important because if your patient is frankly septic, cholangitic, you don't want to actually inject too much of a contrast there. Okay, again, you know your clinical picture, you know how sick your patient is, you've done your imaging, so you know what you're dealing with. What's your therapeutic intent in that procedure? Biliary decompression. You may or may not be able to achieve duct clearance in the single procedure. You don't want to end up injecting too much of a contrast here. Intention in that patient would be just to achieve biliary decompression. Okay.
So one of the word of caution and most of us do that way is that you've got a stricture, you've got a jaundice patient, pass the stricture with the wire first. That's what our practice is. I would go up and then inject. I will not inject otherwise, unless in most cases we have the wire up and then inject, and we know that we'll be able to drain the system. The last thing you want to do is inject in a closed system and then not be able to drain it. So personally, I feel that putting the wire up and then injecting is a much better thing, and most of the time wire goes through most cases. Sometimes you have to where you have to then be careful, inject a little bit just to see where the structure is. That I'm sure is the practice.
Yeah, I think initially, as soon as you go into the papilla, you just need to have a roadmap. Once you have the roadmap, you need to go as possible, and then start injecting, slowly pulling back the catheter. And another important thing, we always say in the seminars that please don't over inject. But to be honest, when we are working, especially when we have a stone or we are facing a person's stone with jaundice, we are always faced with the dilemma that this patient may be having a stricture as well. So in these scenarios, filling up the duct properly, having a clear-cut outline of the anatomy, that becomes very important because small, subtle strictures, they don't come up with an underfilled duct. So you have to go with your clinical judgment. It's not true with this particular thing that don't over-distend the duct. This is not true in each and every case. Does even when you don't want to fill the duct, at times it becomes a need of the procedure to fully fill the duct and then look for the stricture in these patients. Missing an early stricture, especially cholangiocarcinoma in these patients, can be quite dangerous. So be careful when we say these words.
Okay, so just in the interest of time, again, this is what we sort of discussed. Be aware of, again, intrahepatic ducts. Depending on what we are dealing with, is it kind of level 2, level 3, ERCP? Is it sort of Harlow stricture? Is it just a stone disease or a distal stricture? Important of appreciating the intrahepatic ductal anatomy is if you come across a situation like this. Okay, so if you're aware of that, you will not have every case where it's going to be left and then the right duct dividing into right anterior and posterior. Some patients you may find, which duct is this? Is this right anterior or posterior? Going away from the spine is posterior. Anterior is going to go there, top, medial and top. So this is the right posterior. It's coming off from. Okay. So this is again just important to be mindful of. Once you've seen it, then at least if you come across a patient who've got a hilar stricture, then you need to, and if you actually have to stent one side, two side, or three stents, you just need to be mindful how I'm actually going to achieve that. Now, roadmap, again, going back to initial cross-section imaging. Is it trifurcation? Is it not actually right dividing into right anterior posterior, just actually at the hilar is dividing into the both ducts? What's happening to the last one? Is it actually the right duct dividing into two right anterior posterior? Or is actually right posterior joining the common hepatic or the common bile duct? So can be joining at a low insertion as well, in addition to the cystic duct takeoff there. So can cause lots of confusion, but the more normal variation you've seen, easier it will become when we come across a patient who has a pathology on top of an anatomical variation. So some simple principles. We want to limit the scatter, making sure your patient's positioning is appropriate, close to your beam, source of your beam. Most of the time, obviously, at least in our practice, procedures are done in prone. You can do it in lateral, left lateral, but obviously your PD condition increases. Again, you may end up screening, your screening time may go up. And at times you actually have to move your patient's position if you are sort of concerned if there's no filling on the right or the left side. So that may require. So patient change in the patient position. If you're using a C-arm, if it's a fixed, it may be a bit challenging. In some cases, if it's C-arm, you can actually move the C-arm to bring it in a beam direction so that you can align it in the same position as when the patient is lying prone. So you can do all sorts of different things to get an adequate cholangiogram, which then helps you in making decisions. Okay? Hopefully we'll finish off on this. ERCP, you're still relying on filling the ducts and making an interpretation. And at times it becomes really confusing. As I gave you an example earlier on, patient who was referred as a cholangiocarcinoma based on CT scan and MRI scan, but it turned out to be a case of Menitzzi. In one case, it was, at least from the memory, it was a cholangoscopy which made the diagnosis. In some others, it was the EUS which made the diagnosis. So ERCP is great, but in this day and age, we also have access to cholangoscopy in some centers. So if you've got a doubt, please refer your patients to an appropriate facility with access to cholangoscopy. So I'll conclude this session. I think we do want to utilize all different diagnostic modalities we have before we resort to ERCP. Please bear in mind that radiation is a carcinogen. There is a risk to operator, to the wider team. And again, depending on how much time you're actually spending, more and more therapies you're doing, more and more radiation exposure you are going to build up over a period of your career. And most importantly, keeping all those things in mind, we then want to finish a procedure where we have provided adequate images to help facilitate patients' diagnostics and their further management. Thank you very much.
While we're inviting her, 2 points here. I think one is that the good principle in radiology called as low as reasonably reduced. And so when you're doing fluoroscopy, as little as you can do is better for your patient and for yourself. Number one. Number two, you have to have your protection. Okay. It's very important. You've been ignoring it for ages. There is a risk. There are issues that have happened with the patient and with the doctor, and so you need to be careful. So have your lead protection. Ideally, you should have your batches that should tell you how much exposure you've had. Just recently, we had to stop Dr. Naval from operating because we had to stop Dr. Naval from actually doing any screening procedure because her the radiation exposure was much more than what would be safe for her. So we had to stop her and then actually reduce the number of cases she was. हमारे यहाँ वैसे देखिए ना हमारे यहाँ we have we are equally divided as the world is, and mashallah, they're very resilient.
So
पहले चैलेंज तो ये होगा कि प्रॉपर लेट mostly क्योंकि लेट discuss they are not too study or too worried about this उनकी लेट mostly पढ़े होते हैं एक तो ये है कि या तो अपना लेट ले ले अब वो बात आ रही है कौन से वाला लेना है 4 मिलीमीटर का लेना है या 6 मिलीमीटर का लेना है शॉर्ट लेना है लॉन्ग लेना है वो आपको एक चीज होगी so just the simple. So there will be challenge whether you're going to use 4 millimeter or 6 millimeter, because when working in a radiology, for endoscopists, we have to go down to the radiology department to do a ERCP or image guided procedures. So a number of times you'll be using the lead provided by the radiology people, and the lead that they're going to provide to the endoscope is mostly on which is torn. So one way of managing the thing is that buy your own lead. Preferably 6 millimeter, otherwise 4 millimeter is also fine. Since it's heavy, the thicker the lead, heavier the material. So you can have it divided into two pieces. Number two is batch. Radiation protection batch, yes, they are important, but in majority of the centers, after every month, you have to submit it to the radiology people, to the radiation people, to read the dose. And this facility is not available in majority of the centers. For example, where I worked, I had to send it myself to the to another hospital, which was about 7 kilometers away from my place of work, and get it read. And initially, I was doing it religiously, but then I stopped doing it. I'm not sure whether Dr. Saad is doing it regularly or not. In his setup, it's they're doing it regularly, but in my center, because it was an extra hassle, so very soon we started ignoring it. But then that doesn't mean that I've been doing the right thing. Possibly that was not the right thing to do. We should keep sending our batches to the radiation protection unit for verification. Number three is that machine maintenance is not will not be done by you. It is going to be done by the radiology people, and radiation protection is the field of radiation protection agency. Do they visit that unit regularly? Not with the poor standards, with the poor monitoring standards, especially in the private sector. 90% of the time it will not be there. So you'll have to be extra cautious, extra careful in these circumstances.
Just going to two quick things. One, I think Dr. Sajjan earlier asked about the duct size or duct caliber. Our radiologists don't like to hear the word size. They say has to be duct caliber. Anyways, I think what we regard normal is 5 to 6 mm as a normal duct caliber. If after cholecystectomy we add 2 to it, so 2 millimeter further you can add to the caliber of the duct post cholecystectomy, and from 6th decade onwards you add 1 into it. So from every 6th decade onwards you can add. So that's kind of a rough estimate of what a normal caliber duct is. That's what we sort of regard normal as in our practice. And I think one of the other important concepts which Dr. Hassan is now going to explain is, we see a lot of patients who are referred to us for palliative biliary decompression. And I think it becomes a challenging, especially in the cases of hilar obstruction. So,
sorry, you could have mentioned that. Sorry, so one point, just adding to Dr. Niaz's point. So, in most of the centers, we don't have proper remediation. When we're talking about the lead effect, what I've seen is that my observation, you guys can put your light on this. So, that's okay. So, when you're wearing a lead effect and you're doing an ERCP, most of the time you're moving like this, right? So, just to make that position, you move that camera. And the X-ray beam is at the back. So your back is exposed to radiation. So that is the time I think
I've seen Dr. Saad doing it, I've seen a lot of you guys doing it. So we need to move a lot of time, and we are pressing exposure button and all that. So I think a wraparound apron would do the job. So that should be, I think, should be communicated here. Number one. Number two is the lead turtles. The lead turtles below the CMB. So that can limit the exposure because the exposure beam is down the table. And the final thing is lead sheet. Sometimes, if you guys have the opportunity to buy that, we can in front of the patient and in front of the observer.
Good point. Thank you. Very good point.
Okay. Regarding the size, you said something after 60?
So what we do in our practice that obviously is based on sort of this Amsterdam study. After 6th decade of life, we add 1. 7th, 8th, 9th, so we add 1 for every decade.
1 millimeter for
1
every
millimeter.
decade. Okay,
Yes.
okay, thank you.
So, one thing about this cholangiogram, we have been pointing out why it's really important to have a cholangiogram. In the stone cases, why it's very important to know which duct is which one, especially in cases where there is a stricture, a cholangiocarcinoma, a islet stricture. The goal at that point is not just to put a one stent somewhere wherever it goes. So need to understand which segment needs to be drained, which part of the liver needs to be drained. Just for a rough estimate, 1/3 of the liver is on the left side, left segment, 2/3 is on the right. And for any biliary obstruction, especially at the hilar area, you need to drain about 50% of the liver at least. So if you're putting only a stent on the left side, that's basically you're draining only 1/3 of the liver. So that's not going to do the job. And there is segmental, like different segments, that 8 segments of the liver. And then 4 on left side, 4 on right side. And these are the cholangiogram that shows you very nicely which segment is which. So that really becomes important in these cases, like where is the obstruction, what you are trying to drain. And for that matter, it's really important to have a good cholangiogram, 50% contrast, 100% contrast. You can start with the 50. If you really are struggling with visualization with the stone, you can always put a saline in there. That will dilute it for you. And for sometimes, as Dr. Saad mentioned before, for the pancreas one, you really want to don't want to inject too much. It's a closed organ, much closed as compared to the liver. Liver can tolerate a lot more pressure than the pancreas itself. In those cases, probably use a less, use 100% of the contrast as compared to the 50-50, so you don't have to overfill. So bottom line is, good cholangiogram important because you need to know which segments you need to drain, and you need to drain at least 50% of the liver. Yeah.
So I just want to make 2 points. Since we're on radiation, how do you tell? Go back to the. Oh, sorry. Oh, sorry. Go back to that side, because it's important to know. Another aspect of radiation is orientation. How do you know that what you're looking at is the left or the right anterior? Because if your C-arm is not appropriately positioned, then you're going to get mixed up. So how can you tell that this is a true, actually the best one I was looking at these is perhaps this one. How can you tell this is a true AP? Because you're going to get the best orientation on an AP view, right? If you're turned left, right, your orientation is going to change. Your ducts will not look, the left will not necessarily be left. The right may look like left, but that's not the case. Anybody? No. Close, not the ribs. Vertebra, and what in the vertebra? I mean, you see the vertebra, but what specifically about the vertebra? The spinal processes, they have to be head on. Because if you look at somebody AP, they're going to come right at you, right? Or go away from you. I can't remember one or the other. But if you see them sideways, then you're not AP. So you have to move your C-arm angle left or right to make sure that these spinal processes are not like this, but they're coming straight at you. If they're coming straight at you, then you're AP. And that patient's position may be such that you may have to go more than usual. But in a classic slight prone, slight tilt, it'll come towards you a bit. And then it gets in your way because it's now coming to your chest, your head or chest or whatever. So you have to keep that in mind, that the spinal processes have to be coming right at you for a true AP. The other thing is millisieverts, right? We're talking about this unit. How much baseline exposure of radiation do you get in a year in a non-radiation dose sort of place? You have to know your normals. If you don't know your normals, it's all abstract numbers. Good, 3, excellent. So about 3, right? What about how much is a CT scan? Patients will ask you these questions. Major radiation kitni milni hai? You know, they'll say, I'm worried about having an ERCP because of the radiation exposure. Single phase CT. 10 millisieverts. Triple phase CT, 30 millisieverts. Chest X-ray, 0.07 millisieverts. Abdominal X-ray, chest X-ray, 0.03, abdominal X-ray, 0.7. So you need to have a sense, when I'm doing an ERCP, what is the exposure? What if the patient asks me? ERCP is anywhere, quick short one, 3 millisieverts. If you go a bit longer, you can go 10 or more even. So have these numbers, they're available in tables, but have these at least put up in the table somewhere in your room so you can look at them, reference them, and tell the patients. Okay, sorry, that's all I wanted to say. Now let Dr. Hassan take over.
No, that's good. So all these are really important points, and as we go through the course, we're going to keep talking about, and any questions you have, we can answer at that time. We're doing this, right? Cannulation? Okay. And how much time? And a whole day? Okay. So I think it's 11, so probably 30, 40 minutes. That should be fine. Okay. So biliary cannulation. Usually.
Everybody please silence
It is. Okay. Okay. So I always start with this slide about the history of ERCP. A lot of US enthusiasts out there too, but the ERCP started way before the EUS. First case done in 1968. And then if you look at the timeline, sphincterotomy done in 1974. Initially, it was just all the diagnostic ERCP, and then comes along cholangioscopy, then stents and everything. In the United States, nearly 700,000 ERCPs are performed on a yearly basis. In the beginning, before 1996, especially from 1988, 1996, a lot of diagnostic ERCP were being performed. Then we got imaging, CT scan, endoscopic ultrasound, MRCP, and everything. They got really, really better. So the diagnostic role of ERCP basically dropped quite a bit. As Nadeem mentioned before, now mainly ERCP is a therapeutic ERCP. Very few diagnostic indications, not that it's not zero, they are there. It does help in certain instances, but mostly it's going to be a therapeutic ERCP. And we'll talk more about post-ERCP pancreatitis later too, but all those studies which are done, majority of those previously has been related to diagnostic ERCPs as well. So with the therapeutic ERCP, that's the main point, is like that rate should be much lower as if you are just doing it for a therapeutic purpose. So therapy, stones, strictures, obstructive jaundice, epilectomy, SOD type 1, 2, 3 does not exist anymore. It's dead. It's basically a IBS of pancreaticobiliary origin. That's what we call. And then post-obstructive complications like bile leak and for pancreas as well. Few diagnostic indications, especially when you have to do a cholangioscopy, maybe for the purpose of cholangiocarcinoma or PSC, recurrent pancreatitis, no clear etiology of, obvious. These are the very few diagnostic indications, but again, mostly is therapeutic reason. That's what you do that. For the ERCP, obviously, you need to get to the papilla itself, and I usually say it's like when you get to the papilla, study the papilla, talk to the papilla. Every papilla in every patient pretty much might look different. So there's a lot of variations. Some could be a flat papilla, other could be a barely bulging, other could be one-fold, two-fold. Some are really angry, don't even want to take a look at you. They're facing the other way towards the third part of the duodenum. So every papilla is really, really different, but major papilla on the medial wall, in second part of the duodenum, drains bile duct and a ventral pancreatic duct. Minor papilla, a little bit proximal to that, couple of centimeters, and then that drains the dorsal pancreatic duct, like especially in cases of pancreas divisum. Papilla, we use ampulla and papilla, these two terms. Anybody knows the difference? Are they the same thing? Same thing, right? Okay. Yeah, from academic point of view, it is a different. Okay, papilla is different, ampulla is different. Okay, ampulla is the sphincter or part, or the common part where the bile duct and pancreas duct meet and then become that common area. That's called ampulla. Okay. And ampulla, the sphincter of ampulla, then the sphincter of bile duct, sphincter of the pancreas, and then all they get together, drain into the bile duct, and anything which is protruding into the duodenal lumen, all that mucosa, submucosa, all that apparatus is called the papilla. Okay, so these two are different. It's just like plumbing in the wall. All those pipes are ampulla, and the faucet is papilla, basically. That's the difference between those. And we use those very synonymously. It may not make much difference when we do the ERCP, but there is a difference in those by anatomy or academically. Pancreaticobiliary junction, like the common channel, how long that usually is? Less than? I think that's the right way to probably describe. And normal, because when it goes beyond 1 centimeter, then we start talking about abnormal pancreaticobiliary junction. So majority of the time, it's close to 4 to 5 millimeter, but there are going to be a lot of variations. Just like there are more variations in ampulla and this pancreaticobiliary junction as compared to what we see in cholangiograms or what Dr. Nadeem was talking about earlier. So there are a lot of variations in there. So normal common bile duct diameter, Nadeem already mentioned, about 6 millimeter or less. Functional dilation that happens in post-cholecystectomy state, narcotics use, there could be anatomical variations. And after cholecystectomy, if somebody had bile duct diameter or caliber of 4 millimeter, and post-cholecystectomy it becomes 10, that usually is not a normal. It should not increase more than 2 millimeter usually, but sometimes it happens. Gastric bypass patients, they usually develop and they develop a papillary stenosis at times. The duct diameter gets bigger than usual, but as long as they are asymptomatic, it usually is fine in those. For pancreas, we use, this is mostly used for EUS, a rule of 3-2-1, 3 millimeter in the head, 2 millimeter in the body, 1 millimeter in the tail. But when you do a ERCP, you kind of expand it. So it's usually still should not be more than 3 millimeter or so. But that rule may not apply to the ERCP. It may be more like a 322, something like that. Okay. Now, coming to the real thing, cannulation. I think majority of you guys mentioned that that's what you want to do, work on your cannulation success. Can't stress that enough that as soon as you get to the papilla, don't start beating on it. As Waqar Bhai says, if I'm going to say a few things in Urdu, so you're going to be, well, he says, अगर तुम पपेला को एक थप्पड़ मारोगे तो ये तुम्हें 2 थप्पड़ मारेगा, ठीक है? So just remember that. It's just like what I've said is, Dr. Wakari usually says, if you slap the papilla once, it's going to slap you twice. So you have to really talk to it, get it, come to some terms with the papilla, and you cannot come to terms unless you really stop there, talk to it, study the papilla, become a pathologist. And it's really every single papilla is going to be a different technique for that. Some are going to be flat papillas, as I mentioned, other slightly bulging, many folds, every papilla is going to be different, and there's no one technique. You just have to have the principles, have to have a basic technique, but every papilla is going to require a little bit variation in that maneuvering to be successful. Okay. And other thing is like we talk about short position, long position. Majority of the time, short position is preferred, but that is not the case always. Sometimes you have to get the papilla in the right position to cannulate. You may have to go into the long position. And if you look at the long position and short position, in long position, the scope is resting on the greater curvature. Less chance of falling back into the stomach, okay, if you are in a long position. In the case of short position, it's resting on the lesser curvature. So if you are unstable, you can fall back into the stomach, which is okay. It's not a problem. It happens. But I'll talk a bit more during the course. We'll talk about that too, like as you go along, how to prevent from falling back into the stomach. Other thing is colonoscopy is different. ERCP is different. You have to unlearn the colonoscopy. You can do a lot of movements in colonoscopy, but you cannot do that many movements in ERCP. It's a very fine movements which you really have to do. Scope is really maneuvered with the left hand, left wrist, and shoulders. Right hand has nothing to do with it. Okay. The only thing what right hand does is moving the scope in, out, advancing it, pulling it back. And if you have to rotate the scope, torque the scope, it should not be right hand. It should be your position of the shoulders. Because if you rotate with the right hand, it gets busy, you can't take that off the scope. Okay? So that has to be done with your wrist, left hand, shoulders, and how you are facing. You're facing the patient, you're facing your tech, are facing away from the patient completely. That whatever it takes is going to be that movement. That's how you're going to stabilize your position. Other way to stabilize the position is when you're holding the scope, if the wheels of the scope are facing your chest and you turn a little bit to the right, scope hugs around the duodenal apex like that. Much less chance of it falling back as compared to you keep, like this is a patient and you're going this way, it's going to fall back. Okay. So rotating it to the right is going to do like this around the duodenal apex, hug it, and does not fall back. Other is about, I think some of us are so afraid to fall back. As soon as you get to the papilla, you want to lock everything. like wheels, especially the small wheel. And that actually is a hindrance to your cannulation. Okay. So I prefer, sometimes you have to, like if it's based on the anatomy, sometimes you may have to, but majority of the time, I would prefer not to lock until I have cannulated the papilla. At that point, you can lock, that's fine. But to get a good control at cannulation, all the wheels need to be unlocked. I think everybody's, I don't know, Mustafa, what's your approach? Locking the wheels?
Sometimes there's stability once I'm in position. Like once I'm in position and just for stability, if the big wheel needs to stay close to the papilla and it keeps rolling back, then I'll lock it. But especially when you're maneuvering the scope, you need to be very loose and unlocked. But sometimes I lock it. So.
Yes, right up. The same, everybody is pretty much same.
Yeah, I think that as soon as I get to the papilla and the papilla is in position, I lock it. But just the small wheel, not the big wheel.
Okay. Yeah.
When you lock it, then make sure you unlock it before withdrawing the scope.
Oh, we'll come to that. Okay. That's later. I'll come to that. Yeah. That's a good point, but I'm going to come to that in just a second. And other thing is like before you obviously need to see where the orifice is and all that stuff. I will talk about that too. You can, if you don't find the papilla, but you're in the right position, you can even use your comb or cannula, whatever you're going to use to cannulate, move the folds around to really take a look at the papilla. But coming back to the wheels, and it really depends on the situation, but I would say for me personally, 80% of the time, I would not lock the wheels until after I have cannulated the desired duct. Okay. So earlier we talked about that secrets of successful cannulation. I always I have 4 secrets of successful cannulation. Get into the good position to cannulate. Okay. Second one, do a little bit, take extra time, and then try to get into even a better position. Okay. Third one, take a little bit more time to get into a better position. Okay. And the fourth one is still take more time. Okay. There's the position. So to cannulate before you touch the papilla. Now, nothing important more than position itself. This is the video. Show how to pass the scope, right? It's a side view scope, ERCP scope. Endoscope, usually I give an example. It's like our colonoscope. Camera is in the front. You're moving wherever you are looking, that's where your scope is going. ERCP, camera is the side. So you literally are looking upwards to the ceiling and moving forward. Okay. EUS scope, where the ceiling and the wall meets at 45 angle. EUS scope, the camera is 2 centimeters behind the transducer. So your transducer gets way before to the wherever you are going before your camera gets in there. ERCP, take a look at the scope when you go see it. It's at least 1.5 centimeters beyond your camera, the distal end of the ERCP scope too. So your scope tip is going to get first wherever you are trying to go before your camera does. So that's important, because when you are at the papilla, at the pylorus especially, and you're trying to get into the pylorus, and your camera reaches the pylorus, your end of the scope is hitting the bottom of the antrum. So it's not going to get in there. You're going to struggle. Yeah, with the force, you eventually will get through it back and forth, but that's not going to be a traumatic ERCP or endoscopy. So, few other points. When you get through the oropharyngeal area, obviously show that. We will work on that. You get through the esophagus. You're looking at the side wall when you are moving down. You get through the GE junction. What I do is, as soon as I get through the GE junction, I will stop there. Okay? Because if I keep going, usually What happens is you keep going, keep pushing, and you're going to move your wheel unintentionally upward. That is going to retroflex you into the fundus. Always happens. That's like, especially trainees, they do always in the beginning. Once you get to GE junction, make a stop there. Okay. Scope you are holding like that at that time by the time you get to the GE junction. Once beyond that, into the stomach, insufflate the stomach, drop the scope like that. It was at the here like a 90 degree, consider it right here, drop it to 80. When you're dropping the scope, wheels are going to start facing towards the patient. Okay, so we'll do that multiple times, okay, during the course. Dropping the scope, wheels facing towards the patient, that's going to show you the greater curvature, all those folds there. So now folds are going to move right to the towards the right side, towards the antrum. You will advance the scope couple of centimeter and then guide the scope towards the distal body and antrum. So you drop it, get your anatomy, figure it out where you are, insufflate the stomach, see the folds, advance couple of centimeters, lift the scope up, and that will take you towards the distal body and then eventually into the antrum, and then you start moving your scope. Keeping in mind, it's a side view. You're looking on the side wall. Your scope is moving, but you're looking the greater curvature at that time. And once you get into the antrum, that's your second stop. So stop number one, right below the GE junction. Second stop, before the pylorus. And few centimeters before the pylorus, you're going to stop there, look at the pylorus, big wheel a little bit towards you, gently advance the scope, get into the duodenal bulb. That's stop number 3. Stop, like these movements, like right, left, those uncontrolled movements, they are not going to get you anywhere. They will get you somewhere, but not really a good ERCP, and not really a atraumatic ERCP. Stop number 3, duodenal bulb, insufflate again, see where your duodenal apex is. Look, big wheel a little bit towards you before you advance the scope, because you're looking on the medial wall, and then advance the scope. Once you're beyond the apex itself, then move the small wheel away. If you want to lock it briefly there just to reduce the scope, it's fine, but usually you don't have to. Just rotate the scope, small wheel away, torque the scope to the right and pull it back. That will take you to the short scope position. So this is I'm gonna demonstrate that.
So once we drop our hands and release, is the greater curvature of the stomach after G junction?
Yes, the front is on the towards away from is the greater curvature. Yeah. So duodenal bulb, right? And then we call a first part of the duodenum, second part of the duodenum. You like from the duodenal bulb, you have to get into the second part of the duodenum. That's the duodenal apex.
Second part.
No, between the bulb and the second part. That like once you get into the bulb, you don't see a lumen, right? And that it turns a little bit to the right. That's called the duodenal apex, like the end of the duodenum. So this is what I'm going to demonstrate right here. So I went below the GE junction, looked on the greater curvature, stopped that second stop right before the pylorus. You have to let the pylorus in a sunset position, but that should happen few centimeters before you get to the pylorus, okay? Not right at the pylorus. And once you get, now this is on the medial, looking at the medial wall, gently advancing the scope. I know the lumen is down here, but I'm not looking at the whole lumen. It's not even half of the lumen to get there. Small wheel away, rotate the scope to the right, and then pull the scope back. Okay. Any question about passing the scope? No? Okay. That was clear. Okay. And now getting to the cannulation. we usually say is like sometimes there is a reason for failed cannulation. Papilla was too small. If you're seeing really papilla, bile has been flowing through that, majority of the time you're going to be able to cannulate it if you use a proper technique. And sometimes you have to change the accessories, different ways, but usually if the bile is flowing, it should be able to be cannulated one way or the other way. And it's never about pushing harder, like when, especially if you get there, have like a failure at first few attempts, then really you get overwhelmed and then you really start banging on it. So that should not happen. It's going to be about the axis and angle. And if the papilla starts like getting compressed, fold it, that means you are really not doing a good job at that. And get back off the papilla, take another look at it, and see what's going to help you. So now you're at the papilla, you know where the orifice is, and you see how many folds are on there. This is how I usually say. It's like a couple of things here. If you look at the bile duct, when the bile duct enters into the duodenal wall, it's parallel, okay? Like it's coming parallel to the duodenal wall into the papilla. Pancreatic duct, on the other hand, when it enters the papilla or opens, it's straight on it. It goes straight, at least few millimeter of that would be straight, and then it takes a turn up. So when you have to do a selective cannulation, you have to get under the papilla, and for bile duct, it's going to be upwards. For the pancreatic duct, it's going to be straight. Okay. Here is the papilla. You see where the orifice is. You need to know where to touch it. And then the papilla meets the duodenal wall, right? You see there is a bulge on there, 1 or 2, whatever that bulge is. And if you don't see a bulge, you do a tap on suction, the bulge will appear, okay? Now where the papilla meets the duodenal wall, right where it meets it, the center of that concave part or the bulge, the last bulge where it meets the duodenal wall, okay? So from there, the center of that area towards the orifice, you're going to draw an imaginary line, okay? Right here is the orifice, meeting the wall right there. Center of that is kind of right in here, and you see an extra, like slightly extra bulge. From the orifice, in the left upper corner, to the center of that last bulge, which meets the duodenal wall, that's going to be your axis of biliary cannulation. So, doesn't matter how many folds are there. That is always going to be the axis of cannulation. I shouldn't say always because there are variations, but majority of the time, that's what's going to be your. And for pancreatic duct, it's going to be the right upper corner between 1 or 3 o'clock position. The way you do is small wheel away takes you to the axis of biliary cannulation. Small wheel towards you takes you to the pancreas. Nothing more than that. Small wheel away, bile duct, towards you, pancreatic duct straight. So we'll do that during the cases as well.
Can you explain this concept of identifying the axis?
So here, I think we'll explain a bit more during the procedures as well. So you see the orifice right here, right? That's clear. This is not it's more there is only one bulge on this papilla, and that's where the duodenal wall is. So the papilla is meeting the duodenal wall right there. So when you do a little bit suction on your suction button, the bulge will appear right where the papilla meets the duodenal wall. The center of that bulge, from there to the center of the orifice, that would be your biliary axis cannulation. Yes. Okay. And any other question on this concept? Well, what we'll do is like when we do the live cases, we'll show like what we mean by that is, what I mean by that is like which is the axis of cannulation. Okay, and always just have to get underneath the papilla, lay the papilla flat before you really touch it to get that access. Okay. Again, I think it will be better explainable during the procedures as well. I don't know. This is like depends on about your wire and contrast and who pushes, who controls this. There's a short wire. There's a long wire. So your assistant sometimes assists you with the wire. Other times you do it on your own. Doesn't really matter if you have a good assistant and their experience. They really get better at maneuvering the wire. You can use them. Otherwise, you can use you can do push the wire or advance the wire or inject yourself. So it really depends on how experienced your technicians are. So I think we'll talk more about those during the live cases as well. One thing is about like be able to like spinning the wire, you know, the concept of that. Like you have to rotate the wire sometimes really to get through in different directions or to get through the difficult, challenging cannulations as well. So we usually end up using a tone to start with, and there are different type of tones. Some tones, when you bow them, they bow to the left. Other tones, they bow at 12 o'clock. There are rotatable tones as well. For us in our unit, majority of us, we use what we call this Olympus tone, clever cut, but that necessarily doesn't mean that's the only one works. That's what's available. We have other available as well, but that is usually to go tone. VisiGlide wire, majority of us use that, but whatever wire is available to you, majority of the time straight wire, but there's an angled wire as well. Sometimes the orifice is small. You may have to switch it to cannula or a smaller wire, which is fine, but these things come with the experience. You would get to know, but there is no point of wasting a cannula, starting with a cannula and then using a tome unless you're trying to reuse accessories like we do over here. Maybe you want to save the tome and just not maybe start with the cannula. But either way, whatever, for us, we usually start with the tome, and then if needed, then we'll really change it to a cannula. But you should have access to some of these really different accessories, and get yourself familiar with the different accessories, because one thing may not work in every single one of those cases. Now, how you engage the papilla, how you seed the papilla, there are different ways. Some people do with the wire tip, other people do with the cannula tip itself or a tone tip itself. So whatever really way of people doing it, you're gonna with each of us probably have a different way of approaching the papilla, and you will get to learn those. So that's one good thing about that is like there's no only one way of doing the right thing. There are different ways to do the right thing and achieving the goal successfully and safely. For me, you will see in the videos as well and during the cases as well, I use the wire tip to cannulate or engage the papilla, and then either inject or move. First, get the tip over the wire. What the wire tip does for me is I engage the papilla or stabilize the papilla or orifice with the wire tip. And if it starts moving in easily, it keeps going, and then you get the tome over that or cannula. But sometimes it does not happen like that. So once the wire tip is engaged, I will use the cannula tip or tome tip to get into the orifice. That's what's called the engagement of the papilla. Okay. or seeding of the papilla. And then based on that, if the wire is still not moving, sometimes it's going to happen. You can inject a little bit to get an idea, but you don't want to over-inject either. That can lead to submucosal injection. We used to think it's all bad, but lately we found out it's not as bad for needle knife if you have to do that, if it happens. So it sometimes actually helps. That does not necessarily mean you start injecting submucosal. Okay. So others are like simple papillas. When we get to that, usually as soon as you start look at the papilla, bile is flowing. Oh, this is gonna be piece of a cake, and those are the most annoying ones sometimes, right? So first need to figure out like if you are having a difficulty, you need to figure out what the problem is. We are so good, all of us, pointing at the problems, but none of us have a solution to that, right? Majority of the time. So people, this is so like a problem everywhere. A lot of people, 99.9%, I would say, they would point out of the problem but have no solution. Only 0.01% will point out the problem and give you some solution. So here, if you have a problem, you need to figure out what the solution is going to be. I won't talk about equipment, sedation, mainly talk about you and the patient. So for the patient, there are certain factors which could be a troublemaker, and for operator, it's really sometimes hard to really have an insight, but that's going to really help you. First, you have to admit that there is a problem, and then you will be able to find a solution. For the patients, okay, reasons for failed cannulation when there is a challenging. I think some of you already probably heard about Sharpe papilla, right? Anybody wants to tell me? You have heard that before. What is Sharpe? Chinese doll, right? So it could be that, multiple folds, up and over papilla, aberrant relationship, just like we have these variations as Dr. Hami showed earlier in like different biliary anatomy. There could be a variation in biliary and pancreatic orifice, two separate openings. You go into the PD, and then you can't get into the bile duct because there were two separate openings, not realizing that. Then both the septum comes all the way to the biliary orifice. Periampullary diverticulum, at times they are so nice and friendly that it's a piece of cake just to go straight in there. Other times they can make your life miserable. Impacted stone could be a problem, ampullary mass, and then obviously altered anatomy as well. This is a straight shot papilla, what I call, and easier to really cannulate because there are not many folds there. But other times, and then comes this papilla. You see the bile flowing out of that, right? And this is like, you look at it, you know, if you have done enough ERCPs, could be a problematic, okay? Because there are so many folds in there, and this actually is in a better position, but this could be a troublemaker. And in these cases, for me personally, I obviously will try with the tome, but I have noticed that the cannula works much better. It's just like we use an enteroscope, and you pleat like double balloon enteroscope. You pleat the small intestine over the overtube. The cannula does those pleat those folds over it, and usually gives, in my experience, that works better. But here, you have to engage the papilla. You go in there. While it may not move in deep in there, get the tip in there, get the papilla tip, get the tome tip or cannula tip right over there inside. Still, while not moving, do a gentle injection that will give you a roadmap which way you need to maneuver the wire. And sometimes in those cases, you may need an angled wire to maneuver your way around that. So they're like whenever you're having a struggle with anything, start thinking there should be a step 1, step 2, step 3 in the back of your mind. Like what is going to be the next step? And what are you going to use? If that fails, what's going to be the next step? So you need to have really a plan there. And then there is what we call up and over papilla or the bulging papilla. This one also looks like it's going to be easy one. What happens is you use a tome, you go in there, you know, like when you use the tome, we just want to bow it. We think that's magical is going to take us into the bile duct, right? Not always going to be the case. Actually, majority of the time, that's not going to be the case. And you could be close to the papilla. In that case, bow is not going to work at all. From the distance, it might work, but it's again, it's going to be different papilla. But in this case, if you bow the tome, you go in, get the wire, you bow the tome, your tome is going to keep hitting the roof of the papilla. It's never going to get aligned with the actual bile duct because you keep hitting the roof of it. So it's called up and over papilla, and I'll talk a little bit more about that. So this is what, and many times when you go in there, if you use a little bit suction and there is a bigger bulge appearing on the papilla, that's always going to be up and over papilla. Okay. So in those cases, this is what I'm saying, like you get in there, and if you use the tome and keep bowing it, it's going to keep hitting in this area. And you may even puncture the roof with the wire if you really push hard. Okay. In those cases, once you get in, you know that it's nicely engaged in there, then just go ahead and inject a little bit. That would tell you which way you need to move the wire. Once you get in, you have to pull the scope back a little bit, get over that, and then gently advance the scope, and then that will take you in there. So this is not necessarily, we talk about wire-guided cannulation all the time, but sometimes injection is better than the wire-guided because wire is not going to take you anywhere. So injection to do cannulation under injection guidance is not necessarily bad. Here, earlier, I'll start the video in just a second. So what I was talking about, this is the orifice here. This is the first fold, kind of second, third, fourth. Earlier, what we were talking about this concept. So right here is the orifice. If I do a bulge right there, you see the last fold is meeting the duodenal wall right there. This hole is the papilla apparatus. So for me, the biliary axis is going to be, the cannulation axis is going to be from the orifice to the center of the last fold where it meets the duodenal wall. So my tome direction needs to be there in this direction, but I need to get underneath the papilla so it becomes flat for me, and I just can straight go in there, okay? So here, this is, I'm trying to show, like, what is my axis of cannulation, okay? Right there. That's what I'm trying to, this is how I'm gonna, so you see big wheel away from me, it became flat. Now I will just try to guide. This is the wire tip I was talking about. Wire tip cannulation, or engagement of the orifice. Once that goes in, big wheel towards me, that will take my tip in there, and all of a sudden I will feel like it just seeds in there, right there. Like you felt that, like you're seated in right there. Okay. Now, what if the wire is not going in there? I know I'm nicely seated in there. One thing about this is, like when you use the wheels, big wheel towards you, small wheel towards you, pull the scope in or push the scope out, is not strong enough to cause any trauma or any damage there. Only time that you are going to run into problem is when you are pushing hard on the tome or the wire. Okay. So, but those wheels are not strong enough. Here, it was kind of more like at an angle, even though nicely engaged, still not going in there. So I injected just to get an idea. And now, if you see that I'm rotating the scope to the left to give it a kind of to get that trajectory to get above that hump there. So it's a little bit struggling there, but this is really a not edited video. This is the whole calculation part. This is how much time it takes, but you need to have a really good idea of what the problem is, because papilla is nicely engaged. Your wire should be going in if you're maneuvering it, but if it's not going in, there is some problem, okay, with the anatomy. And the way that it was bulging and the big bulge on there means like that needs a little bit direction there. Okay. This is an example of aberrant orientation. Normal is like your pancreatic orifice after swing partment falls down, but usually it's going to be at like a 1 to 3 o'clock, biliary 11 to 12 o'clock position. But sometimes the biliary orifice could be in the area of pancreatic area, and your pancreatic orifice drops further. And sometimes they could be switched at as well, but that is really very uncommon. And then separate openings, you have to realize that because there is really a lot amount of normal tissue in between. And if you go into the PD and did not realize there's a separate opening, you're never going to get into the bile duct. And then this is another one. Here, another point I want to point out, like sometimes you don't see where the papilla is. There is sometimes a small white ridge. You have noticed that under the papilla. Not always, but sometimes there is. So that ridge can guide you where the papilla orifice is. So here in this case, there's a big diverticulum, but you see a bile here, and then you see this small ridge there. Okay. And use your tome to move the folds around. Too much motility, I think we use a Buscopan here if needed, right?
We use atropine diluted,
okay.
1 in 10, because Buscopan IV is not available.
Okay. And we use glucagon. Yeah, for us, I don't think glucagon is available.
Glucagon is available, but what happens is it's very expensive.
Yes.
So we got glucagon, but हम उसको बचाते बचाते एक दफा इतना बचाया कि वो एक्सपायर हो गया.
I think we use glucagon as a patient as well.
Okay. Yeah, we use glucagon all the time, and that's what we do. But that's for the motility. But here you saw that like another thing here from the papilla and orifice. In this case, you have noticed that diverticulum, sometimes the orifice is in, papilla is inside, other times it's on the left side. Rarely it's on the right side. Usually it's at the bottom, inside, or on the left side. But in this case, the important point is, once you have engaged that orifice, and if you move the big wheel towards you, or you push on the tome or the wire, it's going to keep flipping into the diverticulum. So it's not going to really go in the direction of the bile duct. So you really have to be very nice and gentle there. Once you engage it, small wheel towards you, and you may have to lean a little bit towards the left to get that trajectory or direction towards the bile duct. And the same was in this case as well. But once you are in there, inject and can take it up.
In this case, which direction you do the synchrotron?
In this case, yeah, that's a good question. In this case, it's not going actual 11 o'clock position. It's going more towards like a more 1 to 2 o'clock position. Yeah, and because if you look inside diverticulum, your papilla is kind of pushed to the side. And again, like gotta take a look and see where that bulge appears. That bulge is gonna be your guide which way it needs to go. And majority of the time, you will be able to find that bulge. If you're patient, do a little bit suction, not complete suction, tap some suction, and it will appear on that. Okay? आप कुछ कह रहे थे? Okay. Okay. I think time to stop or keep going for a little. Okay. 5 more minutes. Okay. And this papilla in this case, it's really inside the diverticulum. And in this one, I may have to bow and to get the tome in there. But once it's engaged with the wire, should be able to get in there as well. And then this is another example. This is a patient. It'll come in a second, I guess. This is a patient with pancreatic mass. So in this case, you can see it's a very nice papilla. This is probably one of the easiest one it looks like. Because it's not, there are not too many folds. It's kind of a fixed papilla, not moving too much. You see where the biliary orifice is. You see your bulge where it meets the duodenal wall. That imaginary line from the orifice to the center of that last bulge where it meets the duodenal wall. This direction in, like you see that how trying to maintain that direction while cannulating and gently going in. Felt that like giveaway. I'm really in nice place. I have no doubt that I'm in the bile duct, but wire is not going anywhere. Okay. Even gentle maneuvering, not going anywhere. I decide to inject. I'm in the right place, but the stricture is so tight, it's not letting the wire go in. So without injection, I would have, even though I'm in the right place, I still was doubting if I'm in the right place or not. So again, injection is not always harmful. Okay. And this, in this case, ampullary mass, wherever you poke, your tome will go in, I promise you. Okay. So in this one, you have to really look around carefully, see where the orifice is. And then I see like this looks like a papilla, because you see that small tissue, whitish, looks like a ridge there. I'm like, okay, let me just try there. This trauma is from EUS scope because the patient had a EUS right before the ERCP. And this is turned out to be probably one of the easy ones. Okay. And this, like if you really touch with the tome like that, anywhere, it will go in. Seems like you are going in the right place. Okay. But this one, you clearly see that's where the... So basically, again, if you're not careful, you're not looking at it, like not studying it, it's going to be a problem. And you will cause a more trauma to that. This is another one, similar way. Actually, I'll just pass this on. This is an important one concept I want to tell about is, you go to the papilla, nice orifice, you go in, touch it, goes in nicely. You're so excited. And it's a PD. And then she could never find the bile duct. Keep going into the PD, right? So what happens is sometimes, like septum comes all the way to the orifice. Okay? So once you touched it, you went into the PD, you move the septum up. Okay? First it was this, and now it's kind of plastered to the roof of biliary orifice. Okay? So if you keep going into the PD, you can put a wire in there, use a double wire technique, and put a stent in there. But in this case, the only way you're going to be able to get in there is if you use the wire tip, stay right at above, like upper part of that where the orifice is, and just keep trying with the wire tip to get over the septum. So this got a plastered septum. So if you keep going into the PD, just keep that in mind that that may be the problem. Double wire technique, you go into the PD. Once you put the wire into the orifice, then what happens is like it can stabilize your papilla for you. and then it becomes a little bit easier to access it and use a second wire to go in to cannulate the bile duct, or put a stent into the pancreatic duct and then go into the bile duct. So that's a double wire technique. And in this case, this is again the mass, pancreatic mass, ampullary mass with the involvement of the ampulla, and just keeps going. Wire went into the PD. In this case, once you get a wire into a duct, take it, no matter what that is, okay? Because you may not be able to get that back in there. Okay? So that just having a wire in one of the duct is going to be very helpful, because that gives you a landmarks where you need to go with the second wire. So in this case, if you look at it, using it home, and right above the pancreatic duct wire angle, you see the angle, how I'm trying to adjust that angle. Once I get above that, bowing the tone, once it's engaged, pulling it into the scope would straighten it for me to help me get above the septum into the bile duct. And in this case, when the wire went in, it looked like it's still going into the PD. With the pancreatic mass, sometimes that pulls the bile duct towards the pancreatic duct. It seems like the direction is towards the pancreas, but actually it is not. It's the bile duct which is being pulled towards the pancreatic duct. So in this case, looked like the wire when it was going in again into the PD, but that was a different duct, and it went. It was in the right place into the bile duct. So if you did your maneuvering, you pull the tone back after getting into the orifice, angle is right, and your wire goes in easily, just keep going. It still could be a pancreatic duct, but many times it's going to be the bile duct, and you will be in the bile duct. I think that should be enough right now. One thing about the PD cannulation. So when you go into the PD and wire moves in, it's fine. But if it starts bending in there, that means you're going into the one of the side branches, okay? Don't push the wire through that, okay? Pull the wire back, keep the wire into the PD, whatever you got, and then inject the PD. Once you have committed yourself that you're going to go into the pancreatic duct, inject it. Wire-guided cannulation for the bile duct, great. Wire-guided cannulation for pancreatic duct, not always great. Because the wire can puncture the side branch. This is the most under-recognized etiology of post-ERCP pancreatitis. So people would say, I got into PD, but I never injected it, but patient still got the pancreatitis post-ERCP because you perforated the side branch with the wire. So once, I cannot stress that enough, for me personally, if I have committed myself to go into the pancreas, I will inject it first. And then move the wire under the injection guidance, because that would, here in this case, intention was to cannulate the pancreatic duct in this case. That's why I'm using a really small cannula. And if you here injected it, once I am in there, and once it goes in there, next one. So in this case, when the wire goes in, if I have not injected it, you see like how it goes, that wire goes in this direction. That's actually a dorsal duct. It's not a bad sign there, but that could have been a side branch, and if you push too much through that, that's going to perforate that side branch. That's why pull it back, have an idea about the main duct where it is going. I think we'll stop there, and I think it was almost an hour.
So, are there any questions?
Any?
Before we actually move to the next.
Okay. Oh, we have a lot of stuff.
You have Any questions?
So,
if we can just talk in English. So,
sir, when we are trying to granulate the CBD, our wife goes into the PD. What maneuver we should do to granulate the CBD? I usually feel difficulties in this.
yeah, that's what I was talking about. All that there are different reasons. It's if it keeps going, it could be a plastered septum. In those cases, you keep going into the PD, inject, get the wire in there, and should have a pancreatic stent to put a pancreatic stent at the end of the case or during the case, and then use that PD as your guide. Is it a septum which you plastered? Is it a different angle? Because once your wire goes in there, you can use a double wire technique, and that would help you to get in the direction of the bile duct. So after you put that, keeps going in there, you have wire in there, then study again to get into the right angle there. Okay. So that's that was the whole point.
So, the question is, as well as inside the vertical, it's flat. You can't see the bulge even if you do some suction. So, how do you define the extent of synchrotmy in that case?
Yeah, that's a good question. When you are in that there, get the comb in there, roll the comb inside the bile, and then pull it out. When you pull it out, it will, whatever the bulge, whatever the sphincter is visible, it will pull that out. In those cases, I don't do a large sphincterotomy. Okay, I'll do enough of the sphincterotomy to weaken the muscle, and then do a sphincteroplasty.
Sphincteroplasty.
Yeah, in those cases, and also the vertical are the one where you're going to have a post-sphincterotomy bleed, because it's the wall is so thin, the vessels are there, so you're at high risk of having a post-sphincterotomy bleed. So you want to make a cut, but a small cut, and then do a sphincteroplasty.
Sir, is it high risk of sphincteroplasty for as well, causing perforation with diverticulum?
So as long as you're careful, follow the sphincteroplasty rules, I think that's another whole complete, hopefully you will have someone who can explain it. But it should not be sphincteroplasty. I think you guys have a lot of experience, have done a bigger sphincteroplasties too. But I just follow the principle of what is the diameter of the distal bile duct, caliber of the distal bile duct. If it's like a saad, I can tell you probably they have done 15 millimeter in everybody, nothing happens. But this is what the rule I follow is, if it's a 8 millimeter, I don't want to do 15 millimeter.
Is it same for the diverticulum?
Diverticulum as well.
So your concern is that they should. Sorry, your concern is that they should not be perforation.
Yeah.
See, if you got a dilated duct up to 10 millimeter, and that's culminating at the papillary side, which is opening in the diverticulum, and you dilate it up to 10 millimeter, there's not going to be any risk of perforation. But if you start dilating it up to 15 millimeter, definitely you're stretching it a bit too much, and that can give a tear to the mucosa over there. So you have to be just careful on that in assessing the size of the duct and the balloon that you're going to take for the dilatation.
We go back to the basic. What position do you normally keep your patients on? Left lateral, drone, what position? आप लोग जो ERCPs कर रहे हैं, you do it in left lateral and prone. Okay. You have to be very careful, because when you're doing left lateral, you need to understand the radiology. Pancreatic duct CBD start very close to each other, so it's very difficult that way. So you have to keep that in mind if you're doing left lateral. But then I think it's there's very little to choose. I think whatever you're comfortable with, but I know most people who do probe. We ask our anesthetists, whatever the position they think they are comfortable is the position we use. But I think one of the things you will be taught is, because the radiology, the anatomy changes in terms of wire. So you have to be careful, and especially if you're injecting, just be gentle when you're injecting, because you could be the pancreas without getting.
I think one very important thing, we, for example, me or Dr. Saad, who have grown up with the minimum sedation to an optimal sedation. Previously, in our early days, we used to do a ERCP with just a light Xalokin throat spray and midazolam and nalmefene. So people were moving all the time on the table, and we had to have a very good technique to get in the papilla right. That technique comes with time. There's nothing alternative to time and practice. But then it takes time to master this. But with Propofol, the things got better, and once the patient gets intubated, it becomes even easier. So if you're facing with a difficult patient, for a younger patient, for an anxious patient, it's not a bad idea to get the patient intubated right away. When the patient is intubated, it becomes very irrelevant whether you're doing it in a fully supine position or in a prone position, in a right lateral position, left lateral position. So whatever position you want to do, you can go ahead. With Propofol, obviously patient is breathing little hard. At times they desat as well. So you have to work in a close coordination with the anesthetist. He has to put in a nasopharyngeal airway at times to maintain your comfort. Patient should not be breathing too heavily. And when you're using nalmefene and midazolam, obviously people are waking up in between the procedure. Patients are breathing deeply. Patient moving. So it becomes a little more challenging. Towards the end of the day, remember one thing, that it's just like putting a thread into the eye of the needle. You have to be good in putting the thread into the eye of the needle. And that comes with the practice. Practice makes perfect.
We will have a little discussion. There are the small topics that will be covered just when we sit down and we talk. From there, we are going to move to the model training. So we have three models. One would give you experience with cannulation, wire, exchange techniques, testing, etc. So before patients, you can do it on the model. The other model will give you experience with sphincterotomy. And then we have an old model that we started using. These two are homemade, locally made in our own center. The one that we imported from UK, actually, I was looking at it, and I think one of the concepts that I see a lot of time of anti-clock getting the pylorus in front of you, in that particular model will give you that access. So what we'll do is divide you guys into 3-3, and you can rotate. And this particular one is just a concept. So you can actually do that on that particular model. So that way you will have an understanding of how do you bring the pylorus in front of you. Going through, you can actually do the rest as well in that particular model, but I think what is more important is position the model which will give you, which you will use for stenting or cannulation and wire techniques. I think these models you can actually play your scopes, and it gives you almost all the functions, all the issues that or the techniques that you can use to bring the ampulla to the right position, move it left, right, whatever. So I think let's see how you find it. This is this way we're doing it for the first time, and we'll see how it works, and then how do you find, how is it helpful to actually take you through the execution. So we'll move to the room. Yeah. The problem is in that room we don't have a lot of space, so we'll initially take the hands-on guys and the faculty. I mean, whichever faculty wants to. I'll just be there to
No, I'm the observer.
to do nothing.
Name of us है ना.
So at least in the next 2 days and later on, ask questions about it. It is very important that you understand. When you understand this, you'll be easy to read the MRCP as well. That's the only thing I don't need every day. Other than that, I don't look at it. So advisor will be I'll take the faculty, just come with me.